Hello, everyone. I'd like to welcome you today to our Africa Virtual Conference for our third plenary session, which is focusing on a focus on treatment and recovery. I'd like to thank all of you for attending this session. I'd like to thank our partners and our plenary speakers and our moderator, and all of you for attending this session and for making it possible. By way of introduction, I'd like to mention a few things about ISSUP. ISSUP's mission is to establish substance use prevention, treatment, and recovery support as a unique and multidisciplinary field through the professionalism and development of its network of substance use prevention, treatment, and recovery support professionals. We currently have over 15,000 members who currently engage with us through our network and on our website. ISSUP's mission is to bring about our work through digital platforms and channels, through our national chapters and our events in person and online. With our national chapters, I'm the National Chapter Regional Coordinator for Africa, and my name is Michael Brobbey. And with the work we're doing at ISSUP, aside from our website, we have social media channels which we use to promote content every day to inform those who work within the field. With the national chapters we currently have them in 21 countries. And with the events we are having these events take place also online via a variety of webinars, which we hope you will continue to join and participate. For this session, we will have various speakers who will be engaging with us. We also have our moderator, Kim Johnson from ICUDDR, who will be moderating this session. And by way of housekeeping for this event, if you have any questions, feel free to put them within the chat box, which we will endeavor to answer and also to collate for our presenters and speakers to answer at the end of the session. For this session as well, we have interpreters who are available to give interpretations into various languages, which you can access via the chat box, which we will make available. Also note that for most of our speakers, they'll be speaking in English, which interpretation will be made available. One speaker will be speaking in Spanish, and translation of that will also be made available. Please note that for this session, the recording will be made available online for you to access on our website. Finally, I invite all of you attendees, if you're not already members of ISSUP, to go on our website and learn about the work we're doing and to join and become ISSUP members so that you can have access to the excellent content we have within the field of substance use prevention, treatment, and recovery. I'll now hand over the time to our moderator, Kim Johnson, who will be moderating this session. Thank you.
Thank you, Michael. Welcome, everybody. I want to add my welcome. I'm Kim Johnson. I'm the Executive Director of the International Consortium of Universities for Drug Demand Reduction, and I will be introducing our speakers and moderating the questions. I will let you know when we are changing languages, so you have a moment to switch if you need to switch to the interpretation app. So our first speaker this morning is Anja Busse, who is the Program Officer for Prevention, Treatment, and Rehabilitation Section in the Drug Prevention and Health Branch at UNODC. Ms. Busse has been involved since 2005 in the implementation of UNODC's global projects on drug dependence treatment and care in different functions. She's a psychology graduate from the University of Berlin in Germany, with further training in public health from the Medical School Hanover, Germany, in systematic psychotherapy and media pedagogics. Her current functions include the coordination of the UNODC WHO program on drug dependence treatment and care, and I hope you all will join me in welcoming Anja. Anja, take it away.
Thank you so much, Kim, and thank you so much for ISSUP for having us here and giving us the opportunity to talk with all of you today about treatment standards. Let me see if I hope you can start seeing the screen. Maybe not, right? Yes, hopefully now, just a second. I think I just need to change my settings, and here we are. Great. No, and thanks again for having us, but also it's really a great pleasure to see some of the fellow colleagues here on Plenary, some of whom we just recently worked very closely with together. And I also know many of you kind of listening because you have indicated before, so great to have you all here. So what I'll talk about are the UNODC WHO international standards for the treatment of drug use disorder mainly. Maybe just for those of you who really do not know what UNODC is, so we are a UN program that's part of the Secretariat of the United Nations, and with a mandate to address global challenges around drugs, crime, terrorism through technical assistance. And therefore, our executive director, Ms. Ghada Wali, responds directly to the UN Secretary General Antonio Guterres. This is the office where I'm currently talking from, but this is actually how it is seen, even though it seems to be a real photo, in a recent Hollywood movie, the Black Panther movie. So this is how we are featured in there as a place where at the end the world's being saved, of course. The UNODC also has a network of field offices all around the world, including in the region and focus of this ISSUP conference on the African continent. We have a number of regional project and country offices. What I'll, as I said, like to talk with you about is a bit the global situation with regard to drug use disorder treatment, the rationale why the international standards for treatment of drug use disorder were developed, a bit on the content of the standards and how we are disseminating them. So let's go straight into it. And the global situation, the UNODC World Drug Report that comes out every year is usually a good source of information for that. So if we look at the global situation with regard to drug use and dependence, we see that roughly 269 million people worldwide have used at least once in the year 2018 an internationally controlled substance. And more or less 36 million people are estimated to suffer from drug dependence and therefore would be in need of drug treatment. And cannabis still kind of makes the majority of internationally controlled substances being used, with opioids nevertheless creating the biggest burden of disease. Access to treatment remains very limited. Currently, the estimates say that only 1 in 8 people in need of drug treatment has access to it, and the situation is actually even worse for women. And that's while only 1 in 3 people who's using drugs might be a woman, but it's only 1 in 5 people in treatment being a woman. If we look at treatment demand and what substances cause treatment demand, and what I have cycled here are data again from the African region, what we can see is that over the years, whereas cannabis is still the major substance that people are seeking treatment for, the pattern has become much more diverse also in this region. When we look at kind of what do we know about quality in treatment, for example, from the annual report questionnaires that UNODC receives from member states, here we can see that the higher coverage is really reported only for very few interventions, like, for example, counseling or treatment planning, whereas others, no high coverage is reported. Also, when we think a little bit about treatment systems, so 90% of UN member states have reported that they do have a national drug strategy, but the downside here is that nearly 40% of such strategies remain unfunded. So that a little bit was the global situation. Let's look at the rationale why actually the international standards were developed by UNODC and WHO. As likely everybody on this call, and as you have been well trained by ISSUP already, knows, substance dependence is not a failure of will or a failure of strength of character. It's a medical disorder like many others, and it could affect any of us. And dependence has been described as a chronic and relapsing health disorder, right? So nevertheless, situation is, and many of you will know that very well, that people with drug use disorders are excluded from a range of community, social health, educational services, stigma obviously playing a big role, but also lack of capacity. Another really driving reason why the international standards were conceptualized is that there was a need to stop human rights violation in the name of drug treatment. So we could really say, here we have a document, what's in there is treatment, other things are not drug treatment. They are either human rights violations or sometimes meant well, but even though there was a good intention, they might not be working unless they show symptom reduction, that they can show psychological or social functioning improvements or decrease the risk for negative health and social consequences. So this kind of situation has also been taken up by international policymakers, and in the 2009 Political Declaration and Plan of Action on International Cooperation Towards the World Drug Problem, the member states recognized this lack of quality in demand reduction and requested the development and adoption of appropriate healthcare standards. So in the same year, in 2009, also UNODC and WHO started our joint program on drug dependence treatment and care, and kind of with this policy mandate backing us up, in 2016, we brought forward the first draft for field testing of the international standards for treatment of drug use disorders. This kind of draft for field testing has been already recognized in a resolution by the Commission on Narcotic Drugs in the same year that encouraged member states to use these evidence-based international standards and requested UNODC together with WHO to think of the dissemination of the treatment standards. So again, in the same year, also the General Assembly had a special session on drugs in which outcome document, the international standards were also recognized, and it asked for promotion and implementation, and again, the development of national standards and accreditation mechanisms. So then from 2016 to 2020 have been busy years, because actually the field testing of the international standards took place, and now in April 2020 we could actually launch the final version of the international standards. Over 1,200 people from many countries have been involved in the field testing, and if you have been one of them, thank you very much also on this moment. And let's look at the international treatment standards. They are now available for you on our website, at the moment only in English. Translations are underway. So the standards really aim to assist, support and guide UN member states in their efforts to develop and expand quality treatment services that are based on evidence. The standards are guided by 7 principles, which I'll only go through very quickly, like that treatment must be in line with ethical medical standards, that there needs to be coordination between different sectors, such as health, social services, the criminal justice system, and of course, very key, that treatment needs to be based on scientific evidence. There needs to be special treatment for people with special care needs. Treatment services need to be guided by good clinical governance. Treatment needs to be integrated with other health and social services, and monitoring and evaluation is also key. So the treatment standards kind of speak at the system and at the service level, and this pyramid is kind of very central when we speak about treatment systems as they are described in the standards document. So as you know, drug use disorders are at a spectrum from low to higher severity and complexity, and services, so to say, need to meet the demands kind of by different severity levels of the disorder. So in guiding here is this public health principle that we would like to offer the most effective service that at the same time should be least invasive for patients and their families, and at the lowest cost as possible, of course. And therefore, public investment should actually match the volume and type of treatment needed. And if you look at this pyramid, we really should think of investing more also in generic and outpatient kind of healthcare services, and not only in, let's say, high-level residential treatment services in order to be effective. The treatment standards suggest a number of service organization models with a one-stop shop, everything under one roof, maybe being an ideal, but also recognizing that well-organized community-based treatment networks work equally well and are likely more the norm around the world. Treatment standards are suggesting concrete interventions at different settings and at different system levels, and that kind of goes through from community care to generic health and social care, and then to specialized drug use disorder treatment services. Treatment standards are very much organized around treatment settings, of which you here see an overview, and I'll just take you through. So first setting mentioned is community-based outreach, which is really there to engage and provide unconditional community-based services to people with drug use disorders, people using drugs. And this unconditional is very important here in this setting. And this could be kind of services such as the provision of basic support like safety, food, shelter, hygiene, but also here programs such as needle and syringe programs for people injecting drugs, overdose management, overdose prevention, or access to HIV or hepatitis testing and counseling could be implemented. Another setting that is being discussed or mentioned in the standards is that with services or that are not specialized in treatment of people with drug use disorders, but still as these could be health services, right? So mental health services, general hospitals, emergency services where people with drug use disorders might show up also with other problems, and that nevertheless through interventions such as screening, brief interventions, and referral to treatment could become a very important contact point and entry door into the treatment system. Specialized outpatient treatment is really at the core of this pyramid that we've looked at, and also is where the majority of people could receive support. Both psychosocial and evidence-based pharmacological treatment can be implemented here, and it can work very well in conjunction with other health and social services, and is in easy access very often. So specialized short-term inpatient treatment is another setting being discussed. That's maybe more kind of up to, let's say, a few weeks. And this could be to diagnose and manage clinical conditions due to drug use, in some cases to start induction to certain treatment interventions, such as maybe maintenance, pharmacological maintenance treatment, or withdrawal management, especially in more risky circumstances. And for some patients, this is also a good moment to just have a break, let's say. And the last setting being discussed is specialized long-term residential treatment, which really also is an environment that could give people a chance to learn how to maintain abstinence from drug use, to improve their health and personal and social functioning, to learn kind of relapse prevention skills, and prepare, of course, for return to community. So these have been the major settings discussed in the standards. There is another chapter that looks more at the interventions and modalities that to a good extent can be implemented throughout these settings. So here you have again an overview going from screening, brief intervention all the way through recovery management, and I'll go quickly in detail. So one of the first interventions, and we talked already, is screening, brief interventions, and referral, typically being implemented in non-specialized healthcare settings. A number of evidence-based psychosocial interventions are mentioned in the treatment standards based on pre-existing WHO and UNODC guidance, such as cognitive behavioral therapy, contingency management, community reinforcement approach, motivational interviewing, family-oriented treatment approaches, or mutual help groups. Pharmacological interventions can also be implemented in a number of settings, and the treatment standards describe kind of withdrawal management for various substances, and then pharmacological interventions mainly for opioid dependence, but also symptomatic treatment for other substances such as psychostimulants or cannabis, and for opioid dependence, of course, opioid agonist treatments such as methadone and buprenorphine are described, or opioid antagonist treatments as well. And overdose management would also fall under this intervention of pharmacological treatment here. Now, kind of one thing which is maybe more described as a modality would be recovery management. And that, again, is something that goes throughout, kind of to help people maintain benefits that they have gained, including in other treatment modalities, by providing individualized continued support based on needs. And that could mean just staying in contact with a recovery community network. It could also mean continued contact with health providers, for example, for people that are receiving continued pharmacological treatment. So that would be one of the modalities. Also discussed as a special area is treatment of co-occurring conditions, with a number of more psychiatric co-occurring conditions listed, and interventions being described, which are mainly derived from the WHO MHGAP intervention guide. And that includes psychiatric conditions such as self-harm, suicide, depression, anxiety, psychotic disorders, polysubstance use, alcohol use disorders, but also other comorbid physical health conditions that are very prevalent in people with drug use disorders, such as, for example, tuberculosis, HIV, hepatitis, but also, other acute pain, for example, or seizures or so that need to be addressed jointly. The treatment standards also go into detail on interventions for populations with special treatment and care needs, and especially they talk about the special treatment and care needs of adolescents, women and pregnant women, and people in contact with the criminal justice system, while recognizing, of course, that there are larger groups of people with special treatment and care needs, such as homeless people, marginalized people, people with limited access to education, those in rural and remote areas, migrants, refugees, and others. So, and that already brings me to, let's say, the last part of this presentation, where I just want to tell you a little bit about how we are disseminating the international standards for the treatment of drug use disorders, and our, let's say, tools around quality assessment and quality assurance are key in the dissemination strategy for the international standards. And already in the year 2016, when we had the first draft for field testing of the international standards, we hosted an international expert group meeting, and Bronwyn, who will speak after me, was already there at this 2016 meeting. And the idea was to review and make recommendations on how to assess the quality sections of international standards and how to help member states really assess their own treatment services and systems against these international standards. So, and now we do have two quality assurance tools, one on system level and one on the service level, in line with the international standards. And this is, of course, important to have both, because when we talked before about how many countries do have national drug strategies, but that still only a minority of such strategies are funded, that of course has direct impact also on the treatment interventions that can be provided at service level, or there might also be certain legal barriers that make access to treatment at a service difficult, which is nevertheless not, let's say, within the authority of the service alone to change that. So the quality assurance work really, as said, goes in supporting member states to benchmark their own treatment services against the international treatment standards, ideally learn from that, see which areas might be ready for improvement, hopefully work on that through capacity building, and then track a quality improvement over time. That would be the main idea, and UNODC has conducted several pilots and trainings in some countries. So the more in-depth pilots took place in Afghanistan and in Nigeria, but additional trainings at national level also took place, for example, in Indonesia, Vietnam, or Central Asia. And just last week, we finished a training of trainers, so we now count on a group of roughly 25 people with various language abilities who can help us in helping UN member states implementing these quality assessment and quality assurance measures. And for example, in Latin America, a bigger regional program around this is about to start. So I already come to the end. I hope I'm okay in time, because I didn't have a warning yet. So just in summary, the international standards for treatment of drug use disorders They respond to a gap in service provision, like we said in the beginning. I also think it's important that they were really designed to make clear what is treatment and what is not treatment, and to really draw a line, a very red line, to any human rights abuses in the name of drug dependence treatment. They were obviously developed jointly by UNODC and the World Health Organization based on a strong international policy mandate, as I mentioned in the beginning. I just walked you through. They propose how treatment can be provided in different settings with evidence-based interventions that are recommended at the various stages of treatment. Very specific therapeutic interventions are proposed, and they provide a framework also for the development of treatment systems, and are kind of conceptualized also for dissemination, including with a quality assurance tool. So with that, I come to an end. Just to say maybe, and I've put this COVID-19 response here, I mean, one of the reasons we're meeting today online and maybe not face-to-face somewhere is, of course, that we are all affected by a pandemic, and the implementation of the treatment standards that were just launched in this year, in 2020, of course, is being challenged to some extent through the pandemic being there and treatment services needing to adapt, and to a good extent really living up to this challenge. So we hope in many ways that this crisis can also be a chance, right, in which we are learning maybe how to apply measures such as telemedicine and so more, and therefore to make treatment more accessible. But nevertheless, the treatment standards also really need to stand for quality. And thank you very much to all of you for listening. I hope you go on our website. The link is there. Pick up your copy of the International Standards for Treatment of Drug Use Disorders. If you have any questions, our contacts are there, and also our Twitter details, and nowadays also a little hashtag around the International Standards for Treatment of Drug Use Disorders. With that, thank you very much. And
thank you, Anja.
I'll be there.
Thank you so much. If people have questions, remember to write them in the chat box, and we'll cover all the questions at the end. I'm going to go on to introduce our next speaker, who's going to talk about service quality measurement in treatment facilities. This is Dr. Bronwyn, Professor Bronwyn Myers, who is the Deputy Director for Alcohol, Tobacco, and Other Drug Research Unit in the South African Medical Research Council. Dr. Myers is the deputy, well, I just said that. She leads the intervention research substream with a special interest in effectiveness studies and implementation science. She has an honorary appointment with the University of Cape Town's Department of Psychiatry and Mental Health. Over the last 17 years, her research has focused on enhancing access to and the quality of services for people with substance use disorders and co-occurring mental or physical health disorders. Professor Myers has published extensively on the topics of mental and substance use disorders, vulnerable populations, and provision of evidence-based practices. Her expertise on substance use and physical and mental health comorbidities has been acknowledged through invitations to serve on international technical advisory groups for the World Health Organization and UNODC, grant review panels, and through her involvement as an associate editor for several international journals. Professor Myers, thank you and welcome.
Thank you so much. It's a pleasure to be here, and I'm just going to ask Olivia if she would share my presentation for me. Great, thank you so much. So today, this afternoon, I'm going to talk about how can we promote service quality in treatment facilities. I'm going to follow on from Anja's presentation and dig a little bit deeper into why it's important to monitor service quality and the data that we can use, that we can collect while we're providing services that can be used to monitor the quality of services and guide quality improvement initiatives. So let's start by talking about why access to good quality treatment is important. Thank you. The next slide, please. Okay. So access to good quality treatment is important for reducing the burden of substance use disorders, and Anja already touched on this. But we know from the SDGs that the burden of disease associated with substance use disorders is a global concern and a global health priority. And in order to reduce the burden associated with untreated substance use disorders, we need to think about how we can remove both barriers to treatment access, but in many parts of the world, including Africa, and especially Africa, accessing treatment is a rare event. So if an individual has the privilege and the opportunity to access treatment, we also want to optimize their chances of entering recovery and being able to maintain that recovery. And in order to do that, we need to ensure that the services we provide are of high quality and have potential to be effective. So we shouldn't just focus on building more or opening more facilities. We also need to make sure that the facilities are providing good services. And what we know is that a very small percentage of adults with a past year substance use disorder access minimally adequate substance use disorder treatment. So in South Africa, the estimation is that only 2.3% of adults with a past year substance use disorder receive minimally adequate treatment, which is defined as 2 to 3 sessions of counseling. So there are costs and there are harms of offering poor quality treatment. And I think this just builds a compelling case for why monitoring and addressing the quality of treatment is vital. Thank you. Next slide. So what does quality refer to? And sometimes when I ask people this, you get all kinds of responses. But generally, when we're thinking about quality, we're thinking about measuring a service or an event against a defined standard. And this is why the international standards are so helpful. And I'm sure once implemented will help us strengthen our service systems. And the World Health Organization defines quality healthcare as services that
Professor Myers, we've lost your audio. Did something happen on your end?
Can you hear me now?
Yes.
Okay, great. May I continue?
Yes, please do.
Okay. So in order to achieve this, healthcare must be safe, effective, timely, efficient, equitable, and people-centered. Thank you. Next slide. So when thinking about how to understand quality within the context of substance use disorder treatments and how we can go about ensuring that care is of high quality, it's useful to think of quality as a process. And there are various elements that are needed to ensure good quality services. And it's really even at the service design stage that when services are being developed and implemented, that it's useful to think about including best practices. And this is a foundation for ensuring that services are of good quality. But it's not just good enough to have an evidence-based treatment protocol. It's also important to make sure that this protocol is implemented with fidelity as planned. And so fidelity checking and monitoring of the services becomes important. And this is also important to prevent drift to non-evidence-based practices. And then routine monitoring of the quality of services against a set of standards is also important in order to be able to identify gaps or areas that can be improved, and to find ways or aspects of services that could benefit from quality improvement initiatives. But having said all of this, there needs to be some elements that to support staff and services to implement and monitor the quality of care. There needs to be a supportive organization that is on board and committed to providing quality care. There needs to be a culture of quality improvement and wanting to improve services, and staff need to have the right tools and skills in order to provide good quality evidence-based care. So there needs to be enough resources. Sometimes we have an impression that providers are reluctant to monitor services, but if it's framed in a way of thinking about how can we improve our services to make sure that our clients get the best possible chance of recovery, I've found that generally they are very eager to get involved in quality improvements. So data becomes important to improving quality. This data on quality and on service performance is needed for evidence-based decision-making around where services can be improved. But we also need good quality data to ensure that the improvement efforts and interventions that we implement are reaping benefits. So if there's no routine monitoring of substance use disorder services, we don't know how impactful the services are, both for individuals, and we also don't know how impactful our efforts are to improve services. Thank you. So in many parts of the world, very little is known about the quality of services, but if you ask treatment providers, they generally will draw on anecdotal evidence or the observations to talk about how successful their services are and the impact that they have. And we've experienced this in South Africa, and I just want to spend a minute talking about the South African example. So in South Africa, historically, we've had the South African Community Epidemiology Network on Drug Use Project, and it's collected data on treatment admissions, but treatment outcomes haven't been collected as part of that system. So we know who goes to treatment, but we don't know what happens to them once they enter the doors of a facility. Our funders and as part of service monitoring for government public funding have requirements and evaluations that require services to report on throughputs, the number of people they see, and sometimes retention rates, but they aren't required to report on outcomes. So there has been no outcome data. But when we've asked and surveyed providers and we've asked them about how effective they think their services are, more than 80% thought that their services were either effective or very effective. And when we asked them what informed their beliefs about the effectiveness of the services, the vast majority said that these were informed by observations of how well their clients were doing when they left treatment, sometimes family feedback, so collateral information, and anecdotal evidence or reports. So this really wasn't and is no systematic way for collecting outcome data. Thank you. Okay. But many countries share these challenges, and it's not just low and middle income countries, but also high income countries. And so in response to concerns about quality, some of these countries have implemented performance measurement systems for substance abuse and mental health care. And these are systems that routinely collect data on a standardized set of indicators that reflect some aspect of treatment quality. And in relation to the quality assurance processes that are going to be disseminated through and with the international standards that Anja was discussing, the performance measurement systems can facilitate the collection of data to assess how well countries and services are doing in terms of meeting those indicators. Thank you. All right. So what are performance measurement systems? So as I mentioned earlier, they are systems, simply systems that routinely collect data on a standardized set of indicators. And when they're implemented, they can be used to continuously monitor the quality of treatment, identify targets for quality improvement, and evaluate activities to improve performance. So, for example, if staff receive training in cognitive behavioral therapy, the impact of that training can be monitored by looking at, by comparing performance on indicators, outcomes indicators pre and post training. Thank you. Okay. So what are the types of measures that are used in performance measurements? So there are two main types of measures. There are process measures and outcomes measures. Process measures are measures like retention, engagement in treatment, treatment completion, and they really are proxy indicators for how well a person will do once they finish the treatment process, and their pathways to outcomes. So they've been shown like good retention or treatment completion is known to predict better treatment outcomes. Process measures are relatively cheap and easy to collect, and I'll talk a bit about how data on these process measures can be collected. More challenging are outcomes measures. Outcomes measures can be grouped into clinician-reported outcomes or objective outcomes. So, for example, through drug testing or for substance use or through some kind of standardized assessment like the Addiction Severity Index. But more recently, there's been a great emphasis on patient-reported outcomes and patient-reported experiences, because even if treatment shows some positive effect and reduction in substance use, if a patient doesn't feel that it has been of value to them, then we can question the quality of the service. So in terms of sources of data, and this is always a concern for treatment services, and they worry about what kind of financial resources do I have to invest in order to collect these data. But a lot of data is relatively low cost to collect. So most facilities would already have administrative data or data contained in program documents, and this is low cost to collect. But the value can range from sort of low value to high value. It really depends on what data are available, what is needed, and how easily accessible it is. There are also standardized instruments, as I mentioned, like the Addiction Severity Index, but this is often costly. Sometimes you have to buy them, but they're usually very reliable and valid, so they generate excellent data. And then there are patient surveys, and patient surveys would collect information on patient-reported outcomes and patient-reported experience measures. There's a little bit of more cost involved in administrative data because you have to go to the effort of asking patients to complete them. But they can be of medium to high value. They can be tailored to specific indicators. You get a reflection of the patient experience, but they might not always be the most reliable and valid way to measure some indicators. Thank you. So an example from South Africa is we have developed and implemented a performance measurement system for South Africa's substance use services. This is called the Service Quality Measures Initiative. It was initiated in 2008. And really, we wanted a system that was tailored to the needs and priorities of our treatment system. Thank you. So the first step that we did is that we really didn't want to have researchers and academics develop a system that was not useful for providers. And so we started off with assessing the need for such a system and readiness to implement a system with providers. And most providers thought that it would be feasible or very feasible to implement a system for monitoring treatment quality. Most believed that the quality of treatment should be routinely assessed, but they thought that any system needed to be easy to implement. It mustn't duplicate what is already in place. It must be low cost, and it mustn't add any additional burden, administrative burden to them. And that they also needed to be involved in the process, because if it was developed without them, they were unlikely to implement the system. So with this in mind and this advice, we engaged providers in co-developing a system, and we established a national steering committee, which has guided every aspect of the process of developing and implementing the system. And this was a participatory process to ensure that the system was feasible to implement and acceptable to providers. Thank you. Okay. So this slide really outlines all of the steps to developing the system. And the first steps were collectively, we identified domains of measurement or major system goals. We identified performance indicators for each domain. So what we hope to achieve under those goals. We specified the indicators. We developed measurement tools for each indicators. We pilot tested the process. We developed data collection and management and reporting protocols, as well as infrastructure for data collection, management, and reporting. We field tested the system and refined it. And then we've been implementing it in various sites in the Western Cape and more recently in KwaZulu-Natal, which are 2 provinces in South Africa. The initial development of the system was focused on adults, but we've adapted the measures for adolescent substance use services and have been implementing that for some time now as well. Thank you. So what does the system measure? So the major system goals really map onto WHO's goals for quality healthcare. We want treatment to be effective. We need services to be efficient. We want to enhance access to care, so care must be accessible, and overall we want overall good quality of care overall. Thank you. All right. So the system comprises 4 robust tools that we use to collect elements that are used to measure the performance on these our indicators. We have a treatment center profile, which really outlines and maps the resources available at each center and their focus. We have the secondary treatment admission form, which I alluded to earlier, which collects basic demographic and clinical information from everybody who is enrolled into treatment. So that's the sort of the basic information about a patient. We've developed and tested the South African Treatment Service Assessment, SATSA. There's an adult version and an adolescent version. This is a patient survey that collects information on patient-reported outcome and patient-reported experience measures. And we also developed a standardized discharge form. So in our setting, treatment centers were collecting lots of information around discharge and end of treatment, but it was they weren't collecting the same information and the information wasn't comparable. So we standardized the information that they collected. So this slide shows a couple of examples of the indicators in each of the domains that I mentioned, and also how we measure the performance on those indicators. So I'll focus just on the effectiveness domain because I think that's of interest to everyone. And in this domain, we have 4 indicators. We are interested in substance use outcomes. We're interested in social connectedness, which captures like family relationships, return to work, occupational functioning. We're interested in general improved quality of life. And in our setting, HIV risk behavior is very important. So we also measure HIV risk behavior. So methods of measurement for the substance use outcomes include a patient-reported outcome measure, but we also collect administrative data, for example, urine drug analysis tests, as well as objective data from clinicians about a patient's progress in treatments. And I will leave that at there. It's just an example of the kinds of information that the system collects. Thank you. We also wanted to make sure that the implementation process was as simple and compatible as possible with existing service flow to make it easy for services to implement the system. So the system, we've mapped the implementation process onto how patients move through the treatment services. So when a service user is admitted to treatment, the treatment provider would complete the secondary treatment admission form, which they actually have been doing for many years for us anyway. Then at some point, sort of midway through and towards the end of treatment, a service user would complete the SATSA. Generally, this is after 3 to 4 weeks of treatment. And there is some effort if a service user leaves treatment before 3 weeks, there is some efforts to try and reach them to ask them to complete the form. And at the end of treatment, the provider would complete the discharge form. And this is either at the end of the program or after 30 days of not having contact with the service user. And so the form can be completed even if the service user left treatment early. And then at the moment, these forms are collated and they're sent to the MRC for data entry and analysis. And we provide each site with a performance feedback report on an annual basis. Thank you.
Dr. Myers, I apologize. We're going to have to quickly wrap it up because we're past 20 minutes.
Okay. What has helped is that as implementation support. So we've really tried to provide implementation support and training to the providers. And thank you. Next slide. I've mentioned that we've had 5 rounds of implementation in the Western Cape, which has demonstrated feasibility of implementation. And we've noted how the quality of data has improved over time. Thank you. Next slide. Okay. I briefly want to touch on how providers have experienced implementing the system. Even though they were ambivalent at first, they realized that there were many benefits to the information. They liked that it was compatible with existing practices. They found it simple and easy to implement, particularly with the implementation support. And they found the feedback was extremely useful, and they actually did use it to improve quality in certain areas. Thank you. Okay. Anja's already spoken about quality improvement cycles, so I won't repeat this. And I think I just have 2 more slides. And the focus now is about how can we move from provincial implementation to bringing implementation to scale. And after engaging with our National Department of Social Development, who's responsible for funding public substance use services in the country, they've committed to implementing an electronic version of the system, and they are busy identifying a service provider who will be able to move what is now a paper-based system to an electronic system to allow for real-time capture of these data and monitoring of the quality of services. So it's a very exciting time for substance use services and quality in our country. So with that, I am going to end my presentation there. We have publications that we can share with you if you are interested, and I would also just like to thank our funders and partners who have been supportive for about for more than 10 years of working to get the system implemented. Thank you.
Thank you so much. I really hated to interrupt. This is my favorite topic of discussion, so I hated to interrupt, but just to keep everybody on time and able to go on to their next things when we're done. I would like to introduce our next speaker. Before I introduce our next speaker, just to remind people that if you have questions, to go ahead and type them in the chat, and we will have some time, I hope, at the end to do questions and answers. So our next speaker, who will be talking on best practices in treatment and the Universal Treatment Curriculum Training in Africa, is George Murimi, who is the training coordinator for Africa for Colombo Plan Drug Advisory Program. Mr. Murimi has a bachelor's in education, a counseling education master's, diploma in education counseling, and a certificate in administration for certified addiction professionals. and he's also a UPC and a UTC master trainer. Before he worked for DAP, he was the Treatment and Rehabilitation Program Manager at the National Authority for the Campaign Against Alcohol and Drug Abuse, otherwise known as NACADA, in Kenya. And he also served as an administrative officer in the Ministries of Foreign Affairs, the Internal Security, and Environmental and Mineral Resources. And prior to that, he was a high school teacher, which impresses me probably more than everything else. So George, please go ahead.
Thank you very much, Kim, and also thanks to the organizers and the conveners of this conference. We are really proud. I think in the year 2020, we'll be looking for a few things that we'll be proud of, and I think this is one of them. So we sincerely congratulate the organizers and the conveners. I think we equally thank the people who are listening to us, because I think if we didn't have anybody listening to us, we'll be performing to an empty gallery. It would be slightly different. So allow me, ladies and gentlemen.
George,
Yes,
I'm
please.
sorry to interrupt you. It's Joanna
Yes.
at ISSUP. Your camera is currently paused. Would you mind just checking that you go back to your camera to see if we can see you?
Okay. I think, is it paused on my end or your end?
I think it might be paused on your end.
Let's see.
There we go. Thank you very much, George. Sorry to interrupt.
All right, are we good to go? All right, so I'll be talking about best practices in training.
Sorry, George, we just need your presentation as well.
Sure.
I'm making life very difficult.
Oh, sorry. Let's go back again. Do you have it now? Show my screen just.
No, not yet. There we go.
Thank you,
George. Sorry for the interruption.
Oh, okay, thank you for the correction. So allow me to share very shortly on best practices in training with particular focus on the treatment in Africa. So, and by way of introduction, I'll be saying that the Colombo plan has been in existence for many years, I think since the Second World War. But the drug advisory program was formed specifically in the year 1973. And the operations in Africa came in the year 2013 rather. And why we exist as a drug advisory program is, again, based on what has been said by the previous speakers, is that we have a serious shortage of people in prevention, and we also have a serious shortage of people in treatment. This is vis-a-vis the number of people who are consuming drugs and the number of people who are getting into substance use disorders. So we do the following things in the drug advisory program of the Colombo plan. And again, this will also form what I will be speaking about this evening. First of all, we develop curriculum on drug demand reduction. Then secondly, we disseminate the curriculum through best practices. And then finally, we do what we call credentialing, which my colleague Becky will be talking about after I am done. Now, why we do what we do right from the beginning to the middle and to the very end is really a process of professionalization, because we want people in the field who are professionals, people who are going to adhere to certain standards in order to be able to implement the evidence-based practices. And we thank ISSUP for giving us a forum such as today and the many others that they do for us to be able to do what we do. In terms of curriculum development, the only thing I can do tonight is to assure you that our curriculum is developed through a very rigorous system. We go through various steps and various levels. And at every level, we want to assure you that value is added. And in the process of adding value, we also make sure that anything that is not of value is subtracted. So when the curriculum goes through the entire process and comes at the bottom, It is, first of all, extremely comprehensive. It is extremely integrated. It is balanced, and it is evidence-based. So that's why we go through it through the entire process. And we also want to say that the bedrock of every training, the very foundation of every training, is in the curriculum that you form. So once you have a solid curriculum, you can be able to go to the other processes. So far, we have been able to develop a curriculum in prevention. We have been able to develop curriculum in treatment, and we've also been able to develop specialized curriculum, such as what we call the recovery support system, or formerly called the recovery coach. We also have a curriculum for treating women. We also have a curriculum for treating children. We have a curriculum for training prevention, rural treatment and prevention, and community outreach. We have a whole range of curriculum so as to be able to meet the diverse needs in the community. In terms of prevention, and this is important for us as treatment, because prevention is what stops the flood from getting to us in treatment. If prevention works very well, then we are sure that fewer people will need treatment. And the fewer people who will need treatment will come at less severe levels of substance use disorders. So prevention to us in treatment is really, really critical. And so far, two levels of prevention curriculum have been developed. One is what we call the coordinators series, or that's meant for managers and supervisors. And the other one is what is meant for practitioners or implementers or specialists. In terms of the curriculum of interest to us this evening is the Universal Treatment Curriculum, which we call the UTC. This one again is divided into two. We have the basic level that has the 8 courses running from course 1 to course 2, which you can be able to see over there, then course 3, course 4, course 5, course 6, course 7, and course 8. And here we encourage anybody who's going into the training to go through the entire series of training on the UTC. When there is time, we run the entire UTC in a country in probably about an year. But for a certain group of people where there is no time, we are able to organize what we call walkthrough trainings, just to give them an overview what it's all about so that they're able to run with the material. Now, once you have gone through the basic UTC levels, the 8 courses, then you will be able to meet Becky for the credentialing examination, after which then you are eligible to be a recipient of the advanced UTC courses. Now, these ones are more because they run from UTC 9 all the way to UTC 22. And for purposes of this evening, I've just listed a few. Now, on average, we don't take you through the entire courses of the advanced level, but we normally ask you to select 1 or 2 per year, based on the needs of the country. Then we ask ourselves, what is training, particularly in terms of training for people in treatment? Now, I want to say that it's a very systematic process. It's highly structured. It follows certain steps, and I'll come to that in a short while. Secondly, it's a process by which people gain knowledge, and then they develop skills. And much, much more important is to be able to acquire the right attitudes for that particular profession. Now, this is done by several means. Instruction is one of them, and then practical activities is the other. And the practical activities here goes beyond what we are used to include such aspects as coaching and mentoring. And the end result is improved performance. If you're going to look at the ask concept that we use in training, the ask concept looks at training as a means of filling up a gap between where people are right now and where they're expected to be. And to be able to get there, they have to be able to acquire certain attitudes, they have to be able to acquire certain skills, and they have to be able to acquire certain knowledge. If you want to rank those by difficulty to develop in people, now this is the interesting part, that whereas attitude is what we want for people to get much more than anything else, It is certainly the most difficult, the most challenging, and the one that comes over a longer time period. Skills is the second, and it's moderately difficult to get. Now, knowledge is the easiest. Now, we structure our trainings to make sure that all the things that are supposed to be acquired, knowledge in terms of the difficulty, skills in terms of the moderateness in difficulty, and knowledge in terms of ease, all of them are acquired if people are going to perform what we want them to perform. We have had it said by the previous presenters that we're talking about quality treatment. If we are going to get quality treatment, we must also be able to have quality training. If quality training is going to help the people in the profession, of course, first of all, maintain the qualified products, all the products we have there, including the curriculum you're talking about, maintain the qualified services that you're talking about, achieve high treatment standards, and of course, learn new technology and the new products, always new products, new tools, revisions. And quality training also helps in terms of improving communication and relationships and teamwork in the people who are working. In terms of best practices, in training, 4 have been identified for us. First of all, is you must be able to identify your audience and the performance challenges before you begin. For if you don't identify the people who are going to be recipient for training, and we have seen this in experience, sometimes you will train people who are better placed to do prevention, then you kind of feel like you are wasting your bullets. So you must be able to identify your audience and the performance challenges. Then you must be able to create a very comprehensive plan for mobility. How do you mobilize resources? How do you mobilize people? How do you mobilize the curriculum? How do you mobilize the policymakers? So you must be able to create a very comprehensive plan for mobility. And that must also have some elements of flexibility, because things are not always very solid on the ground. They tend to vary. Once in a while, you may have to have a plan for flexibility. A very good example is the current pandemic we're finding ourselves in. We had completely prepared ourselves for face-to-face, and we had set ourselves to it. But here we are with the pandemic, we cannot travel. And even if we travel, you'll not allow us into your rooms. So we must be able to create a plan for flexibility, and certainly a plan for accessibility. A fourth best practice is issues of rich media. If you have only one kind of media, then you tend to have what we call monotony. People tend to fall out, people tend to get bored. So you must always have a very rich media. In the process, you must also have very interactive activities. Remember, the people we are training in, the people we are focusing on in terms of training are adults, and they have many other cares. They have many other concerns in life. So if you don't have extremely interactive activities, you lose them in the process. You also need to have a very engaging script. The fourth thing in terms of best practices in training, you must be able to incorporate assessments. Test where your trainees are at the beginning of the course, test where they are maybe somewhere in the middle, and test them at the very end to find out, have they benefited, or would you need to do something to be able to improve or offer remedial teaching or training. We said that training is very systematic. It's highly structured. It follows certain steps. Now, the 9 steps have been outlined to us, and it is very, very crucial to make sure that the training that we conduct in terms of treatment have to be able to follow the 9 steps very systematically, very logically, in a very structured manner. And I know from experience, having been in the trainings out there with you people, is that sometimes some of our trainings are almost like guerrilla warfare. We take a few things here and there, we go out, we train and come back, but we don't follow the steps. We want to say that probably going forward, it's important for us to make sure that our trainings follow the very 9 steps. And we want to assure you that if you ever invite us to conduct the UTC in your country, we work out with you as a focal people or the people who are being trained or training to follow all the 9 steps very logically from the beginning need, from making sure that we assess the needs to eventually planning for future at the very bottom. So training is systematic and we need to follow the steps that have been outlined for us. Now, when we train people, we expect or we really want to make sure that they retain as much material as possible. Now, if we are to merely lecture them, I think we have been warned here and before that they retain only about 5%, sometimes less. Unfortunately, lecturing is what we are used to, and it's probably the easiest thing to do, you know, just to stand there, do your thing and walk out. But if we just going to use the lecture method, only about 5% of the materials will be retained. If our trainees will read, then the retention rate increases. If we use audiovisuals, the retention rates increase. When we use demonstrations, then we have better results. If we have discussions, even better. When they practice what they have been trained, the retention rate is extremely high. Finally, if they teach or they train others, then we are sure they'll probably be able to retain everything that they have been trained on. Now, what we do in the UTC as it is, we use all the methods that have all the activities that we have outlined there, but we also expect that what we have trained them on, they actually practice and preferably report back to us. Then we also expect them to train others in a process which we call echo training. Now that ensures that the retention of materials is as high as possible. If they don't retain the materials, we are sure we are losing out in terms of what we're trying to do and the end results. Becky here, who comes to eventually test and to evaluate the trainees, I'm sure she'll find out if she was to conduct an analysis later on. Probably the people who pass to the very highest are the ones who have been able to retain the maximum, probably were able to do in terms of practicing what they were trained on and teaching the others. And I actually have some examples of countries where I know they were able to practice what they were trained on, and I know they taught others because they reported back to us. And we can assure you the success rates were very high. There are some other incidences where some of these things have not been possible, maybe because of the political situations. And unfortunately, that has been reflected in the examinations. In terms of training, in terms of learning, we tend to train all people as if they are the same. We want to use the same styles, the same techniques, the same methods. But really, our learners are as diverse as there. And some who have a visual preference for learning in terms of what they see, the images, the graphs, they retain, they learn much more. Others are better listeners. Others, of course, learn by doing, and of course, they're very active. You give them a group work, give them group activities, they learn better. There are others who we say their verbal preference is higher. They learn best when they discuss. Unfortunately, sometimes we want to say that they are verbal. Let's not say they are verbal. Let's just say, or they're talkative. Let's just say that when they verbalize, they memorize better, they internalize better, and they conceptualize better. Really, diversities of learning styles. Equally, we have incorporated all these different as training styles into our UTC. So the UTC curriculum itself has all this into considerations. We even go further. During the training, we ensure that we have 2 or 3 trainers so that they are able to take care of the different kind of learners. That way we are able to take care of the entire class other than focusing on a few people. We want to remind ourselves that we are dealing with adult learners. And this is very different from the ones we used to train in school. I have been a school teacher. I know. I've also had some short stints at universities. The people we are training are adult learners, and they are distinctly different. First of all, they are very autonomous and self-directed. That I think we need to bear in mind as we do what we are doing. Secondly, they have a foundation of life experiences. which we need to build on their experiences and their knowledge. So we try with the UTC not to come as if we know it all, as if we just want to bombard them with what we know and what we have. We build on what they have. We build on what they know. We build on their experiences. Adult learners are equally goal-oriented, and they are also relevancy-oriented. They are practical, and they need to be shown respect. Critical things that are supposed to be taken into consideration. And we want to say that in the UTC, we take care of those. And at the end of the UTC, we always conduct a feedback session. We ask them, do you think we are doing these things according to you as an adult learner? And they give us a feedback. They tell us, please improve on certain areas. That way we keep on improving what we're doing so that eventually we are able to deliver our materials as per the kind of clientele we have who are adult learners. I've been speaking in very generic terms of what we do in the entire world. And we are very fortunate as Colombo plan to be probably participating in about 63 countries of the world. But allow me, ladies and gentlemen, to just focus on what we are doing in Africa. And Africa is a large continent, the second largest in the world by size and population. And we have about 56 countries. So what is it that we are doing in these 56 countries? Well, so far we haven't been able to get to every one of them, but there's a lot of work that is ongoing, not only in terms of training, but in terms of the entire spectrum of DDR. In terms of training and epidemiology, this color here represents the colors that have already been recipients. And when you consider that this work is only from 2013, you can be able to feel that we are making good progress as a continent. And we want to thank INL. So we have training and epidemiology in the countries shaded in this color. We also have epidemiology network, which has commenced, and the African Union were able to share with us the other day what they've done. There's a few countries where only training has happened. We have several countries which have formed ISSUP national chapters, and they're very helpful because they're able to consolidate all the DDR activities into one solid framework. We have a few countries which are been able to form the ICUDDR, represented here by Kim, who is the president. And recently she was able to conduct a walkthrough for the various universities in the continent. We also have a community coalition against drug abuse, CADCA, a few countries represented in green. Finally, we have the International Technology Transfer Center, ITTC. So far, you can be able to see it's only South Africa which has been able to get the four of them, the different aspects in one shell. So in Africa, only in training, we have been able to go into the following countries. In West Africa, and we want to say, courtesy of the people who are there, we've been able to move into Liberia. We've had Ghana on the board. We have Nigeria, we have Benin, we have Ivory Coast, we have Togo, we have Gambia, we have Niger, we have Burkina Faso. In Cameroon, so far, is a representative of Central Africa. In North Africa, here we've been able to commence in Tunisia and Egypt. And then in East Africa, we have the countries listed over there: Kenya, Tanzania, Uganda, Ethiopia, Seychelles. In the Southern Africa, where this conference is being hosted, we've been able to get to Botswana, South Africa, Mozambique, Namibia, Eswatini, and Eswatini, which are 22 countries. Certainly, we could not be able to do all those things simply by ourselves as the Colombo plan. Therefore, we have been working very closely.
I'm going to interrupt you to say you got to wrap it up. We're out of time. 2
more minutes. So we have at the very top, INL giving us policy, giving us funds, and giving us direction. We also have the African Union playing a very pivotal role in terms of bringing us together. We have the UNODC, ISSUP, and ICUDDR. The various governments have been very, very helpful. Regional organizational bodies such as ECOWAS, highly helpful. People in recovery, the master trainers, the civil societies, and the national trainers, extremely helpful. And for that, we want to say thank you. So it's only with collaboration that we can be able to do all those things that we have been able to do. Normally, on average, we just take about 25 people, we train them, and then they train other people. That way we're able to increase exponentially just by way of seeding. So by way of wrapping, we have a few of the images which show what we have done in South Africa with the help of the very, very helpful Deputy Minister, and the different activities which have been done in South Africa and Eswatini on the bottom. We also have what we have done in Nigeria, one group at the Federal Neuropsychiatric Hospital, and then another group with the assistance of UNODC. We also have trainings which have been conducted in Ghana, in Burkina Faso, in Cameroon, in Botswana, and so on and so forth. So time does not permit us to say the things that we have done in Tunisia, and the things we have done in Egypt, and the things we have done in Niger, and Seychelles, and among others. But ladies and gentlemen, we can say that if we are going to collaborate the way we are doing, we probably should be able to get to 50% of the countries in Africa and Middle East by the year 2025. And we are doing this to increase, first of all, the quantity, but more importantly, the quality of the people who are delivering the services. Finally, we want to say that as we do these things, we will need to continually review what works. And what works is what we will be running with. What does not work, we will certainly shield it. Ladies and gentlemen, I wish to thank you for your kind attention.
Thank you, George. Sorry to have rushed you at the end. If you have questions, do write them in the chat. We are going to take time at the end. Even if we go over time a little bit, we will make sure we have time at the end to answer questions. Our next speaker, who will be talking about credentialing and certification, is Becky Vaughn, who is the director of the Global Center for Credentialing and Certification, GCCC, at Colombo, the Colombo Plan, the Drug Advisory Program. Becky has been working in the addictions field for over 35 years. I think I've known her for 30 of those. She started at St. Jude's Recovery Center in Atlanta, Georgia, and her work turned to public policy and association leadership in 1992 when she established the first provider association in Georgia. As the CEO of the Georgia Council on Substance Abuse, she focused on legislative advocacy and acted as a community catalyst on issues around prevention, treatment, recovery, homelessness, and drug courts, including the passage of many bills and securing budget resources. In 2008, she became the CEO of the State Associations of Addiction Services, which was a United States national organization. After they merged with the National Council for Behavioral Health, Becky served as the newly created Vice President for Addictions and built the addiction presence and services at the council until 2016. She is currently supporting the Colombo Plan in Sri Lanka as the director of the Global Center for Credentialing, which you all may remember. So GCCC, which used to be ICCE, and promotes a professionalized workforce to reduce the demand for alcohol and other drugs. Becky served on numerous state and U.S. federal committees and panels and speaks on the topic in a variety of settings. She received her degrees from the University of Georgia and Georgia State University. She's a former teacher and the mother of 4, and because of that, she's passionate about preventing and finding solutions to the far-reaching problems caused by untreated addiction. Becky, welcome and thank you.
Thanks. Sorry about that. Thanks, Kim. I think you're right. I think we have known each other for quite a while when it comes to working in this field. And I am delighted to be part of this panel with the amazing people who clearly are just as passionate as I am about this issue. And I'm also glad to kind of come now after hearing about quality treatment and the need for facility certification and all the best practices that George, my colleague, just talked about, to talk about sort of the next step in what we're doing. So it's always a little bit difficult for me in terms of speaking to an empty screen or audience. And so here's how I like to sort of picture my folks. Let's see if I can make my slides move. I truly believe that anybody that's on this call that is interested in learning more and doing more to help treat a devastating disease of addiction and substance use disorders is a true superhero. And I like to remind you of that because very often nobody is thanking you. Your days are difficult. As a matter of fact, it seems like you're in this alone very often. But I want to thank you for what you do. Very often people get well, get back into society, and you never hear about the great things you've done. On the other hand, I'm asking you to be fearless and ready to take on the challenge of what we're trying to do. No matter where you are, there is still a lot to do. So despite me calling you a superhero, I know that in actuality, this is probably how you feel. No matter whether you're working at home during COVID or in an office other times, it is overwhelming. And you probably often spend your nights worrying about either someone you're working with, your agency, but it is a difficult profession to be in. So to give you a little bit of an idea about GCCC, the Global Center for Credentialing and Certification, we envision a world where everyone has access to quality services that promote health and well-being of individuals, families, and communities. That's our vision, and so that drives our mission to provide experience verification and appropriate exams to ensure that governments and other employers are hiring and utilizing the most qualified professionals. We think that improves the likelihood of positive outcomes for those individual families and communities. So, as you've already heard, we know how to do this. We know that we must provide prevention and promotion services. We must intervene with treatment services, and we must support recovery for those to be able to continue that life. We also know that primary care has to be engaged at all those levels. It can't be done by itself. And that people need a safe and sober place to live in order to take advantage of these services. So given the fact that we know everything, why the heck am I here and what do I have to offer to that scenario? Well, sadly, despite knowing all this, there are still many speed bumps and roadblocks in the way for people to get to that place of recovery. Stigma is still a big problem in many places. This is a disease that is often not treated as the health condition that it is, and people are discriminated against and making it more difficult to get the services. The cost of services alone can be a big barrier for people to get into treatment. And the very lack of services in so many places, even if people are motivated and wanting to get engaged. Sadly, even with all of those, we have a workforce shortage. And that has been probably the biggest barrier in most cases to making this a reality. So, what are we about? We have a professional process. As George was saying, as basically everybody has been saying, we need professionals in this field. So we start with passionate people. Everybody that I've worked with in this field, I have found to be passionate about this issue. They certainly don't get in it for the money. So there must be something else that's driving them to want to help in this way. We train, we educate. George mentioned the universal curriculums that we have for prevention, for treatment, and for recovery support. We also have specialty curriculums, for example, for women's intervention and specialty services for children, our child intervention for living drug-free. So we train, we educate, and then we want them to get some experience, some practical clinical experience. So we want them to work in our treatment centers, in our treatment settings, whatever that might be. And why do we then need more than training? Basically, for two big reasons. First, do no harm. And this is a universal situation where we want to make sure that this very vulnerable population is not taken advantage of in the name of treatment. And then second, there needs to be a minimum standard. So defining an operationally provider certification criteria so that you know when you hire someone, or your government knows that you have that minimum set of skills and education. So the way we do that is to provide an exam. We test people so that they can demonstrate that they do have that knowledge and skills in order to be able to do that. Currently, we have ICAP credentialed people in 64 countries around the world, and our passing rate on the exam is right around 69%, which is close to where it should be. If it was a high passing rate, we would question whether our exam is too easy. If it was a very low passing rate, we would question whether we're actually testing people on what they need to know. So after they take the exam, they pass the exam, they have clinical experience, they are awarded the Global Center for Credentialing and Certification, ICAP credential, the International Certified Addiction Professional. And then we want them to practice some more. And then it starts over. Check your passion, make sure you're getting continuing education, practice some more, renew that credential, and keep doing what you're doing. In addition to our professionals working on this, we also know that we need more supervision. Oversight is absolutely essential for people working in this field, and that is still very much a shortage of people who can do that. As part of our future plans, we are hoping to develop a credential for that clinical supervision. So back to workforce development. We see this very often as a 3, 4, 6 level stool, but I want to at least acknowledge how we partner in our current situation. We are only one piece. ISSUP, as you all know, is an important part of our professionals being able to network with each other. And ICUDDR, as most of you know by now, is also our extremely important and crucial partner in the world of universities and colleges, making sure people get that training that they need. So what's the future for GCCC? We know that training is important, but even before COVID and the world pandemic, there were still many people who could not access person-to-person training. While we see that mode as the very best, we want to be able to reach out to people who cannot access that version. So we are in the process of developing that same curriculum in an online training. Course 2 will be coming out very soon. The treatment for substance use disorders, the continuum of care for addiction professionals. And this will be available around the world for people to be able to access this same quality training in an online independent version. There are also courses being developed for online that also have a trainer, and that will be coming out very soon too. But we are very excited about the idea of access to an independent course. People can do it at their own pace. It can serve many purposes. It can even be a review for people before they're ready to take the exam. So we see a lot of use in this that is coming soon. Course 2 should be out by the end of the year, and then next year we should be able to get the majority of the other basic courses 1 through 8 finished so that they can also be posted and be accessible. The next thing that's been going on is the majority of our exams have been done in person, paper and pencil. We have also been able to give exams in a computer center setting. But again, that's not possible for everybody, and particularly right now in the midst of our pandemic, it is definitely difficult to do, particularly in countries where people are not allowed to gather in an enclosed space. So we are about to offer probably our first group coming up later this month or next month, a remote monitoring option for people. This way, people can take their exam from their home or their office as long as they have a camera on their computer, and we have a proctor who is watching them take the exam. This is becoming very popular with universities around the world during this pandemic, and the protocols are set up and it is working very well. Before the pandemic, we were also working on giving a draft calendar for a date for each country so that they could plan around what their training around when their exam would be. This way, not only our participants could know what they need to be working around, but also the trainers. So we will get that back in place as soon as we can go back to person-to-person exams. It is still important. It's just on hold for right now. Basically, we look at a desk like this as not being a good thing. We know that we have to try things. We need to do things in order to make things happen, or else we will not make any gains in this. Our goal is for every country to have a network of professional providers to address the needs of addiction. And that's where we are headed. So what am I asking you today? I want you to be involved in education and training, as you've heard about earlier. I want you to push for certification requirements in your country. We know that until that happens, people will not necessarily see the need for it, and we won't have the kind of workforce that we need. And of course, we want you to join ISSUP and or ICUDDR, depending on what part of the field you're working on. Folks, there's some urgency around this. This is a devastating disease and people are dying. And this is the way we address it, by moving forward and making sure we have the workforce that can provide the best practices that will ultimately get us to the best outcomes. We're in this together all over the world, but there's still plenty to do. So I need you to stay strong, to care about what's happening, and to get involved in whatever way makes sense for you. I appreciate your time today. I appreciate what you're doing in whatever area of the world you're working in. Please don't hesitate to reach out to me if you have any questions about any of this, or even how we can help you reach those goals in your own country. And as Kim has already said, I'll be around to answer any questions you might have. Thanks again.
Thanks, Becky. So as Becky said, if you have questions, go ahead and type them into the chat. We have been getting some questions and we will keep time at the end to answer them. We now have 2 case studies on treatment programs, one in Africa, which we'll start with, and the second one is in Latin America. The first case study is being presented by Bawo James, who is the Publicity Secretary of Mobilization for ISSUP in Nigeria, and is also the Executive Director of the Manifold Rehabilitation Foundation. He's a national trainer on the UTC, a master trainer for TreatNet, and a UNODC focal point. He's also head of the Substance Abuse Treatment Education and Research Unit for the Federal Neuropsychiatric Hospital in Benin City, Nigeria. Mr. James, are you ready?
I am.
Thanks. Welcome.
Thank you very much. Good afternoon, good evening, wherever you may be. And thank you to the organizers for the opportunity to talk about evidence-based treatment programs in Nigeria. I'll just follow this outline for this case study. We'll look at background of drug problems, the objectives for the intervention, activities, our results, challenges, and then the lessons that we have learned. Everybody in the substance abuse field in the country knows that we have a huge problem with psychoactive drug use. And Interestingly, from the drug use survey that was published in 2018, the prevalence of drug use problems in Nigeria was estimated to be some 14.4%. And the survey estimates that this is about 14.4 million people that have used drugs at any one time in the past year. And what was interesting was that this prevalence exceeded the global prevalence for 2016 of about 5.6%. And in the earlier presentation by Anja, we see that that prevalence rate is still about 5.6% globally from her presentation. We also note from that particular survey that about 2/3 of high-risk users, and the survey identifies high-risk users as people who use crack cocaine, amphetamines, or inject drugs. 2/3 indicated that they needed treatment, but sadly, 40% of these persons were unable to access any form of intervention. And the identified barriers were people did not know about services, they could not access the service, the number of centers were inadequate, and so sometimes even if they knew where a service was, for logistic reasons, they could not access it. And also there was high cost of care, and then not many services were offering evidence-based care. There was this survey that was done about a decade ago, published by Onifade et al. And one of the high points of his report was, of their report, was that there were very few drug treatment services in Nigeria. He also noted that the treatment centers that were available were very skewed in terms of geographic distribution, mostly in the southwest part of Nigeria, and that many drug treatment centers had limited funding, particularly private treatment centers run by NGOs. And also there was a poor network amongst the treatment centers. The UNODC, in its assessment, there's this response to drugs and other related organized crime, conducted a survey also about some 7-8 years ago. And they also noted in their survey for drug treatment centers at that time that there was a lack of standardized tools for assessment and treatment planning. Also noted that low number of staff working in drug abuse treatment services were trained, and many centers lacked very basic equipment. So against this backdrop, the federal government of Nigeria, working through the Federal Ministry of Health and the National Drug Law Enforcement Agency, with support from the UNODC, had the objective to improve the quality, availability, and spread of evidence-based treatment services in Nigeria as one of the strategic pillars for the 2015 to 2019 Drug Control Master Plan. To this end, there were some activities, and one of which was the development of the national minimum standards for drug dependence treatment in Nigeria. These standards really are just a country-level adaptation of the WHO standards, and it was published in 2015. The benefit of this standard is that it facilitates, creates the opportunity for any new drug treatment service or current or available service to benchmark the services that they're offering, provide a guide for new services, and because it has been adapted for Nigeria, it addresses more bottlenecks or logistic constraints that many services in Nigeria would complain about, and also has a component for auditing existing services and getting user feedback. The other thing that the collaboration between the federal government and the UNODC achieved was to facilitate capacity for 11 geographically spread drug treatment centers. Initially, there were just 10 public funded hospitals, and then one was a civil society organization that was a private service. And we can see from this figure of the map of Nigeria, the services were designated as either model treatment centers or regional training hubs. The idea was this: to set up a center that met the minimum standards for drug treatment services in the country, so that other available services would look at this service and then scale up the services that they were currently offering, or model any new service they were to offer according to what was available at the model treatment centers, and also regional training hubs where there was capacity in the sense that we had master trainers to be able to deliver training in the respective geopolitical zones for drug treatment services. So the model treatment centers are indicated in red, and some centers doubled as both model treatment centers and regional training hubs are indicated in the yellow triangles. And also there was similar capacity building for NDLEA counseling centers. Another activity that also happened to this end was the training of practitioners, because I earlier said that the lack of trained professionals was one of the things that earlier studies and surveys had shown. And at the last count, over 1,200 practitioners had been trained using the TreatNet. And then there's continuous training available because there are 24 national master trainers and 90 trainers on the TreatNet. And also, I may not be very accurate now with this number, but about 50 national trainers are there for the universal treatment curriculum. And about 400 practitioners have been trained on the UTC, and a smaller proportion have been credentialed. And that's why I'm excited with the last presentation about the opportunity for remote proctoring for the exams, which will allow a lot more persons to get credentialed for drug treatment services in the country. So what we see, what I have here are things that I believe in this case study are crucial for anyone to offer quality evidence-based treatment. One, adherence to the minimum standards. The country has minimum standards now, and anyone can look at it and benchmark the service that he's currently offering. But to be able to, I speak about management buy-in here. That's because in rolling out drug treatment services or improving the quality of services that we have, the approach has been to look at services that are available at the top of the pyramid, where we talk about long stay services or services that are embedded within hospitals. And because the way drug treatment services are offered, many times management of these facilities need a lot of convincing so that they can buy into what drug treatment services essentially entail. And it's not just because it's client-led, and it's not just something you do to ensure that, oh, we are offering some kind of service, but the service itself is not holistic. Another benefit has also been network of providers, because the trainings that have occurred at different levels, either on the TreatNet or on the UTC, has allowed a lot of interaction to happen. And also with the formation of ISSUP in Nigeria as well, has allowed for professionals to interact and to be able to compare notes, which is very important. Although it would be desirable if there is a formal network of providers which will facilitate easy referral, prevent people moving from one place to the other and not being able to carry on from the benefits that they have gotten from one treatment center to another. Also crucial is staff training and retraining, with the emphasis on retraining, and then the approach to having multidisciplinary network. So we look at the example for my treatment center, which is a model treatment center, as well as a regional training hub. And before 2012, 2013, we did not have an evidence-based or client-centered treatment program. What we were just offering was, you come in, we recognize that you have a drug problem. And because, like the survey has shown, that many people in Nigeria, the common drugs of abuse is cannabis and then prescription opiates. That many of our clients tend to have a lot of comorbid psychological problems. So the emphasis previously had been a focus on the comorbidities, and there was not really much focus in getting clients motivated to quit or get treatment for substance use, but that is now available. Also, the percentage of appropriately trained staff at that time was about 10%, but as a result of these interventions that I've spoken about, it's risen now to 100%. We didn't have training and mentorship capacity, but that is now available. We've been able to mentor or midwife a evidence-based treatment program in 2 other teaching hospitals that are close to us. And our service user satisfaction from our assessment of our clients had jumped from an average of 22% before 2012 to 93%. And I think that this will be the case at many, if not all, the other treatment programs that went through this process of scaling up and training and capacity building. What challenges have we seen? One, staff adaptation. You have to use staff that you already have, whether they are nurses, they are clinical psychologists, social workers, or doctors, and you have to train them. And so there was initially a lot of resistance. But one thing is that once someone receives adequate training, it leads to a change in attitude and in the way that they deliver service. Also, multidisciplinary collaboration and client-centered care. There's always a tendency for health workers to be paternalistic with care, and it took quite a lot of adjusting to switch health workers to understand that the clients should direct in some, you're only to advise, all right, but to direct really to a large extent the way that he wants his care plan to go. And this has helped a lot because it has prevented burnout. It has ensured that there is more retention of the client and that we're able to follow the client into recovery. Another problem has been availability and affordability of medications for managing addictions. We have a lot of skill with psychosocial interventions, but when it comes to medication management, the cost of these drugs many times is prohibitive and also not routinely available, although methadone is available in the country, but sometimes access is an issue. The other challenge
James, I'm sorry to interrupt, but I'm going to ask you to
Okay. Another challenge we have now is cost of care and also funding. And then lastly, the other challenge is brain drain. So what are the lessons we've learned? One, stakeholder buy-in is important for the success of the program. Networks that we have developed as a result of national and regional level trainings have been invaluable. It's helped it's helped us a lot with evidence-based practice and practice-based evidence. And also training and retraining are invaluable for successful programs because the attrition rate sometimes for staff is very high. And lastly, teams make the difference rather than excellent individuals. So teamwork creates a sense of ownership of the program and facilitates skill and knowledge transfer. Thank you very much for listening.
Thank you, Dr. James. If you have questions, please go ahead and post them to the chat. We will continue, even though we're coming up on the hour now, we will continue until we finish and respond to some questions. So now is the time, if you have been listening in English to the live broadcast, to switch to the interpretation app, which there should be instructions for in the chat box, because our next speaker will be in Spanish. And I'm going to apologize for my poor pronunciations for all these things because while my colleagues in Latin America and Spain are trying to help me do a better job with Spanish, I am not good at it. So our final speaker for this session is Dr. Yuri Cutipé, who is a psychiatrist. He has a master's degree in social policy at the Universidad Nacional Mayor de San Marcos and a Ph.D. in public health at the Universidad Peruano Cayetano Heredia. He later obtained his postgraduate studies in collective health and senior management at the National School of Public Administration. He was the director of collective health from 2009 to 2014 of the National Institute of Mental Health Honorario Delgado Hideo Noguchi. Since 2014, he's been appointed as the Director of Mental Health of the Ministry of Health of Peru. And I would like to welcome Dr. Cutipé. Is he here? Cutipé. Are we having technical difficulties or are we okay?
We're just looking. Oh, sorry, Ella.
I was just going to say he's connected. We're just, I think he needs to unmute. Dr. Cutipé, are you able to unmute, please?
Oh, here he is.
And the microphone also, please. The microphone.
Necesita habilitar el micrófono.
Sí, ya está habilitado.
Sí,
Okay.
sí, está bien, gracias.
Buenos días. Muchas gracias por la invitación. Estamos en Perú muy agradecidos por permitirnos intervenir como un caso para ser tomado en cuenta en nuestros hermanos países del África, de acuerdo a su realidad, ¿no? Perú es un país que está en Sudamérica, tiene alrededor de 32 millones de habitantes, ¿no? Y respecto a los problemas por consumo de drogas, fundamentalmente tenemos el problema del consumo de alcohol, los problemas de salud mental asociados al consumo de alcohol forman parte de una proporción importante de la carga de enfermedad en el país.
Disculpe, doctor Cutipé. Sí, ¿podría poner la presentación en modo de presentación?
De acuerdo.
Excelente,
Gracias.
perfecto, muchas gracias.
Okay. Entonces, decía que el principal problema en Perú respecto al consumo de sustancias es el consumo fundamentalmente de alcohol, ¿no? Aproximadamente el 54% de la población tiene un problema por consumo de drogas legales, especialmente alcohol, ¿no? Hay un porcentaje relativamente bajo respecto al problema de consumo de drogas ilegales, especialmente en la marihuana. Se considera que aproximadamente el 1% de la población tiene problemas por consumo de marihuana, ¿no? Esto significa que en un país de 32 millones de habitantes, aproximadamente tenemos alrededor de 2.800.000 personas con problemas por consumo de sustancias, especialmente alcohol, ¿no? Perdón, ¿se ve la pantalla?
Sí, la vemos.
Yo perdí la...
y tengo que también hacer un anuncio, perdón por interrumpir. Just to let you all know that there is English interpretation. So if you could all go to the actual Spanish stream to listen to the English interpretation. Thank you very much. Tengo que también hacer un anuncio, perdón por interrumpir. Just to let you all know that there is English interpretation. So if you could all go to the actual Spanish stream to listen to the English interpretation. Thank you very much. Tengo que también hacer un anuncio, perdón por interrumpir. Just to let you all know that
Muchas gracias. ¿Puedo continuar?
Sí, gracias.
Ok, gracias. Sí, bueno, entonces nosotros en Perú tenemos que atender aproximadamente cada año a cerca de 500.000 de personas que tienen problemas por dependencia o uso problemático de alcohol, ¿no? Y alrededor de 45.000 personas que tienen problemas por uso o dependencia a marihuana, ¿no? Que son los problemas más frecuentes en consumo de sustancias que tenemos en Perú. Por dependencia o uso problemático de alcohol. También Perú se encuentra en un proceso de reforma de la atención de salud mental desde hace 5 años, ¿no? Y estamos migrando de acuerdo a la ley de salud mental aprobada hace 2 años. Estamos migrando de un modelo de atención centrado en la enfermedad mental, en la atención psicológico-psiquiátrica, en el hospital psiquiátrico, en el tratamiento psiquiátrico psicológico y finalmente en la exclusión social de las personas de la población que tiene problemas de salud mental, especialmente problemas severos como son los problemas por consumo de sustancias. Y estamos migrando hacia un modelo de atención basado no en la enfermedad mental o en el enfermo mental, sino teniendo como centro al ciudadano con problemas de salud mental, sus necesidades y sus derechos, así como también hacia un paradigma de la atención por un equipo interdisciplinario y en una red de servicios de salud, ¿no? Con un enfoque comunitario y no solamente en el tratamiento psiquiátrico psicológico, sino en el cuidado de la salud mental y en la inclusión social que haga posible también el aspirar a la recuperación total o a la recuperación subjetiva para quienes tienen un problema de discapacidad finalmente, de discapacidad psicosocial. Para esto, el Perú viene implementando en cada territorio donde aproximadamente de 100.000 habitantes, donde hay una red de salud, viene balanceando la atención de la salud con atención de salud mental, que incluye la atención de personas que tienen problemas por uso de sustancias, ¿no? Y en esta red de servicios de salud se incluyen, se fortalece los centros de atención primaria, con inclusión de psicólogos y capacitación al equipo básico de salud, en la identificación de problemas de salud mental, incluidos los de consumo de sustancias, y además de atenciones breves, ¿no? Y en segundo lugar, con la implementación de servicios de salud mental, los centros de salud mental comunitaria, ¿no? Que trabajan vinculados con el primer nivel de atención, supervisando el primer nivel de atención y también vinculados con el hospital local, el hospital general local, donde venimos implementando unidades de hospitalización breve, inclusive para personas con problemas por intoxicación por sustancias, ¿no? Así como también unidades de hospital de día. Dentro del mismo territorio venimos implementando hogares protegidos o residencias protegidas con servicios de rehabilitación psicosocial y rehabilitación laboral. Esto en un territorio de 100.000 habitantes, ¿no? De modo que aspiramos a que en cada territorio haya capacidad, ¿no? Para poder resolver los problemas de diversa severidad que puedan tener las personas en su salud mental, ¿no? El centro, los servicios que se constituyen en el eje de atención son los centros de salud mental comunitaria, en el eje de atención en cada territorio, ¿no? Un centro de salud mental comunitaria tiene 4 servicios. Uno de ellos es para la prevención y control de problemas por consumo de sustancias o adicciones, ¿no? Este servicio tiene 3 funciones básicas, ¿no? El proveer la atención especializada, interdisciplinaria, ¿no? Que implica el diagnóstico y tratamiento, ¿no? La intervención individual y grupal, las intervenciones familiares, las visitas domiciliarias. Algunos de los usuarios entran al programa de continuidad de cuidados, que es un programa de seguimiento permanente en los lugares donde la persona se desenvuelve, ¿no? Así como un sistema de referencia y contrarreferencia dentro del territorio según las necesidades de atención, que pueden ser la hospitalización, el tener protección residencial o el que pueda ser seguido desde la atención primaria con intervenciones mínimas según sea el caso, ¿no? También el servicio de adicciones del Centro de Salud Mental Comunitaria hace la supervisión clínica al primer nivel de atención, ¿no? Y además activa la red social y comunitaria del territorio justamente para hacer posible el soporte en red de las personas que tienen problemas por consumo, ¿no? En eso es muy importante la vinculación que tenemos con organizaciones de la sociedad civil que están orientadas a justamente dar soporte a las personas que tienen problemas por consumo, como Alcohólicos Anónimos, Narcóticos Anónimos u otro tipo de organizaciones que pueden dar los soportes que cada caso requiere. El Perú viene en los últimos años implementando estos servicios, los centros de salud mental comunitaria que incluyen el servicio de adicciones, ¿no? Con un equipo interdisciplinario y que trabajan con la atención primaria. Y como ustedes pueden ver, en los últimos años se ha desarrollado un proceso acelerado de implementación, ¿no? Actualmente tenemos en todo el país 155 centros de salud mental, 24 unidades de hospitalización en salud mental y adicciones, ¿no? Así como 11 hogares protegidos. Este año estamos implementando 50 centros de salud mental más, 6 unidades de hospitalización y 35 hogares protegidos, y con metas al 2021 que esperamos lograrlas, porque esto nos permitirá realmente hacer posible que las personas tengan un acceso cercano cuando tengan dificultades, y también a implementar las acciones de prevención primaria y secundaria en cada territorio. Esto ha permitido que, como ustedes pueden ver en la curva de casos atendidos por problemas de salud mental y de conducta asociados al consumo de alcohol y otras sustancias, que desde el 2015 esta curva haya aumentado. Históricamente atendíamos entre 10.000 y 15.000 casos cada año, y actualmente estamos llegando a atender cerca a 70.000 casos, como ha sido en el año 2019. Esto ha sido posible gracias justamente a que estamos en un proceso intenso de expansión de estos servicios de salud mental en todos los territorios, ¿no? Para el presente año muy diferente por la pandemia, ¿no? Nuestros servicios han bajado su capacidad de producción, especialmente durante los meses de marzo, abril, en que llegó la epidemia a Perú. Y sin embargo, desde el mes de mayo vamos en un aumento progresivo en la recuperación de la atención de los casos que ya venían siendo atendidos, implementando especialmente intervenciones de telemedicina, tanto individuales como grupales, ¿no? Entonces, estamos en un proceso intenso de fortalecimiento de los servicios de salud mental comunitaria a través con tecnología para hacer posible que la continuidad de las acciones estén aseguradas, ¿no? En este proceso, para terminar, en este proceso ha sido muy importante la ayuda de las organizaciones de la sociedad civil, tanto dentro del país como de la cooperación internacional. Fundamentalmente para formar en cada territorio esta red comunitaria que pueda acompañar a los servicios de salud mental comunitarios para dar el soporte correspondiente a las personas que tienen estos problemas, pero también para desarrollar las capacidades, las competencias en los equipos multidisciplinarios, ¿no? Respecto al primer aspecto, hemos tenido un fuerte apoyo de grupos, especialmente de los colectivos LGTBIQ, que han hecho posible que también podamos desarrollar, que estos servicios sean desarrollados con sensibilidad a la diversidad sexual. Así como Alcohólicos Anónimos y Narcóticos Anónimos, y también el apoyo fundamentalmente de OEAS y CAT, del Plan Colombo, de la Embajada Americana, que ha hecho posible que podamos desarrollar un programa de desarrollo de capacidades, como se ha explicado por el representante del Plan Colombo, muy minucioso en todos los territorios donde vamos implementando estos servicios, especialmente a través del Protocolo Universal de Tratamiento, ¿no? Que ha hecho especialmente en sus capítulos correspondientes atención con sensibilidad de género y de diversidad sexual. Eso esperamos que en los próximos años podamos tener un mayor desarrollo y obviamente mucha mayor investigación para demostrar los resultados que vamos teniendo en beneficio de la población, especialmente de la población que tiene problemas por consumo de sustancias, que finalmente están marginadas por la propia sociedad. Muchas gracias.
Thank you. Gracias. Now is the time for questions. So if we could have all of the panelists turn on their cameras if they're able to. And George, since I see you now, I will ask you the first question. I think this could go to you and Becky. The first question is, how can we access the training? So either the live training or the online training when it's available.
For now, we have posted quite a number of information of the trainings on the ISSUP website, but we are also accessible to anyone who wants maybe more tailored information. And I think, so if we can have maybe some of the questions or some of the emails, we will be able to respond to each one of them. And I think the easiest way for now is to connect them to the ISSUP national chapters in those countries, because they have an awareness of what is going on in the country. But if there are no national chapters in those countries, I think we should be able to see how else we can be able to reach out to them. Just give us the email addresses and we should be able to respond.
Great, thank you. Becky, do you want to add anything about the online training or? No sound.
Sure, as soon as we have, oh, sorry. Can you hear me?
Yeah, no, yeah.
Okay,
oh, no.
As soon as we have it ready to post, that's weird. Can you hear me now?
Yeah.
Okay, as soon as we have the new course ready to post, we will put out the information of the link to the learning platform, and it'll also be available, that information will also be available on our website and the DAP website.
Great, thank you. Anja, this question I think is to you, but I think others may be able to respond as well, is how do we respond to services that we know are not adhering to the standards? So I'm presuming most people that are participating are providers themselves or you know, organization, you know, people running organizations. What can they do if they are aware of places where organizations or individuals are not adhering to the standards?
Yeah, I think that's a great question, and I think also depends, of course, in which role you are. But from our perspective, of course, it's always about support, right? So if there are already people out there that, at least with good intention, are ready to provide treatment services, and they may lack capacity or they may lack resources, so that's of course a good basis to work on, and definitely nobody should be turned down, but rather be encouraged and be given the tools to improve. And as we were saying, I mean, some things can be done at a service level, right? And other things in reality need higher level advocacy and support kind of from either national or regional governments in order to get that going. But I think the main point is rather to encourage people to continue providing treatment services. Of course, as said, there are sometimes red lines, right? So when we come across things like human rights abuses, a more stricter approach might need to be taken. So somebody mentioned, you know, that the first principle, of course, is do no harm, right? So that needs to be ensured, of course. But everything else, so to say, can be worked with and supported and encouraged.
I'm just wondering if Dr. Myers, Dr. James, or Dr. Cutipé, if you, within the country context of your countries, if you could respond to that same question.
Okay. What I found is that many programs want to offer evidence-based treatment, and what works, I've seen as a strategy, is you tell them the benefits of offering evidence-based treatment. And one of it would include that they have better client satisfaction, better client retention as well. right? And so when they see that they can tie evidence-based treatment to less stress for health professionals and also better customer satisfaction, it's easy for them to implement it.
I think from the South African perspective, our approach has always been to try and work with providers to improve services. And I mean, services often are along a continuum of quality, with some having a lot of improvements, with a room for improvements, and others being really sort of high functioning and very well established, and also trying to partner where there's concern about a service, trying to partner that service with a service that is more established and is doing better in terms of quality, to try and mentor them in terms of improvement. So it's definitely a sort of a mentoring and a capacity building approach. We have had instances where there have been human rights abuses, and that's taken very seriously. Of course, treatment providers don't want to be all tarnished with the same brush. And I think in those instances, it's important to work with, if it's possible, to work with countries and authorities to make sure that there are reporting processes in place, so that it can come to the attention of people who are able to intervene with those centres.
I think, Kim, sorry, I think you're on mute.
Oh, sorry. So I was saying, as Dr. Cutipé, you've had extraordinary growth in the number of programs available and the amount of treatment you've been able to provide in Peru in just a couple of years. And so I'm wondering if you can respond to that question around what you do about organizations that aren't adhering to the standards given that rapid growth. Is he able to hear the interpretation? Oh, go ahead.
Bien, sí. En Perú pensamos que es muy importante para el mejoramiento, alcanzar los estándares de calidad de los servicios privados, que los servicios públicos primero alcancen estos estándares, ¿no? Es muy importante que el Estado sea el modelo de atención es necesario tener en cuenta que la calidad cuesta, ¿no? Y que cuando el Estado exige a los servicios privados tener una calidad de servicio, y muchos de estos pasan a ser informales, ¿no? Por no tener capacidad de financiamiento. Entonces el Estado tiene que abordar también el financiamiento del mejoramiento de la calidad de atención, ¿no? Primero, desde sus servicios, ¿no? Y luego de los servicios privados, de modo que sea efectivo el servicio para la población en cualquiera de estos dos ámbitos.
Okay. Next question is, and I think this again can go to multiple people, is how do you go about obtaining accurate data? Is there a particular strategy knowing that there's stigma and secrecy around substance use disorders? How do you get accurate, whether it's epidemiological data, accurate data for assessing the various outcomes that you're measuring for services? Maybe I'll start with you, Dr. Myers, but I think probably multiple people could respond to that question.
Gosh, you could talk for hours about how to get accurate data. So I'll just give sort of a few headlines. The first is the questions that you ask. So finding the right way of asking the questions and using tools, and there's some tools that are valid and reliable, and there are many excellent screening tools and assessment tools that are publicly accessible and have been validated for use in multiple countries. If you have a specific question, you can email me and I can try and point you in the right direction. So using the right instruments is the first starting point. The second point is about who is asking the questions. And so having, if it's staff, it's making sure the staff are trained, that they are able to develop rapport with the person and make them feel comfortable so that they feel open and free to answer as openly as possible, and don't feel like there is going to be a negative consequence for disclosing their substance use. And I guess the third part is about the settings and who is going to have access to that information. So if someone is going to be telling you some sort of very highly sensitive information about involvement in illicit activities that might get them imprisoned, they will really want reassurance that the data is not going to be accessible by the sort of the police or criminal justice sectors. So I think it's about setting, it's about training of the interviewers or people collecting the data, and it's about how we collect the data.
Thank you. Does anyone want to add to that?
Also, just to add that the timing of when questions are asked. Sometimes are you asking the question just when the person has started treatment or at the end of treatment? And also, if you're trying to get information in a group setting, or if you are trying to get information from the individual just for more. And I think the others that Professor Myers has said, they're very important.
Thank you. I think I'll make this the last question that I'll ask, so that because it's we're already a half hour over, and people probably have places to be. But the last question is similar to that one, but it has to do with the context of how do we attempt to meet the standards. And Anja, maybe I'll direct this to you, but I think again this could be anyone could chime in on this question. Given that particularly in Africa, most countries are low income anyway, and now under the scenario of COVID-19, not only are we under lockdowns and all of that, but it's also having an effect on the economy in almost every country in the world. And so how are there thoughts that you have about how people can achieve the standards, how countries can achieve the standards given the constraints that we now have?
And I think on one level, also the international standards for treatment of drug use disorders are aspirational, right? So, I mean, there's maybe hardly any place in the world where everything is perfect. So I think so in that sense, it's really good to do a bit of an analysis, a quality assessment rather, and see where are we doing good already and where are we doing not so good, and then to see in the areas where we are doing not so good, what can we actually prioritize, right? And involve a number of stakeholders. I mean, I think, and I'm thinking of a few examples, including from West East Africa, but also maybe talking to the examples we have heard here, that it's important to bring a lot of stakeholders on board. So I've once observed the process of developing a specialized treatment service in Senegal, and it was really an amazing process that took a long time. People came together, kind of community service providers, the ministries, various ministries, medical service providers, various donors. And it took a while, but I mean, that really helped to set up now specialized treatment service there, which offers some services that are unique in West Africa, at least till this moment. So I think, so there are good examples, things have worked. And obviously, I mean, under the conditions of COVID, as I tried to say, I mean, it's a huge crisis, of course. But there are these chances in the crisis, right? So that we maybe learn, we have done, I mean, like all of you, we are here with 700 people online. So people manage, they find a way, right, to also approach to other means of communication, learning, providing services. Other things that we have seen in some countries when we talk, for example, about health justice coordination, that there have been some, let's say, compassionate prison releases to address prison overcrowding, and also people with drug use disorders to some extent have been included there. So things we have been advocating maybe before to offer better services in the community. You know, there was a huge pressure in a way that came, and therefore COVID also became an opportunity in but nevertheless, right, the challenge is there. We are still in the middle of it. We need to see how good in the end services and countries will manage to respond, and it's up to all of us. But I think, yeah, I mean, prioritization and taking it a step at a time, treatment standards are building blocks, as long as some of the basic principles are there, right? And that's basic medical ethics, so to say, that need to be ensured. Everything else, so to say, can be developed over time, I would say.
Thank you. Does anyone else want to add to that before I turn it over to Michael? No. Well, you got the last word, Anja. So Michael, I'm going to turn it back to you to close us up, I think is the right procedure. And I'm also going to mention that, you know, there are discussion boards on the ISSUP website, and treatment is one of them. And so if there are questions that that you raised that didn't get answered here because we ran out of time, I would propose that you post them on the treatment discussion board, and I will challenge ISSUP to make sure that they get answered by one of our experts. So Michael, are you here to close for us, or is someone else going to do that?
Yeah, I am here. Thank you so much, Kim, for moderating the session, and thank you to all the speakers for your involvement and for the things that you've shared with us. And I'd like to say especially thank you to all the attendees for attending this session, and we hope you'll continue to take part with the other sessions that we have. And from all of us at ISSUP, we thank you and wish you a good morning or a good day wherever you are in the world. Thank you. Bye-bye.